I'm delighted to be here to present this case on the management of drug-drug interaction with COVID-19 drugs. These are my disclosure. So several therapeutic options are now available for the treatment of non-hospitalized adults with mild to moderate COVID-19 who are at high risk of disease progression. A number of factors affect the selection of the treatment, and these factors include first, the availability of the drug, the feasibility of administering parenteral medication, the clinical efficacy, which requires also to take into account the regional prevalence of variant. For instance, sotrovimab was shown to have a reduced activity against Omicron BA.2 subvariant, which is now dominant in several parts of the world, reason why the NIH COVID-19 treatment guidelines no longer recommend the use of sotrovimab. Finally, another important point to consider is the potential for drug-drug interaction. And among these drugs, nirmatrelvir, ritonavir has the highest potential for drug-drug interaction. And this is explained to the fact that nirmatrelvir is given together with the pharmacokinetic booster ritonavir, which is notably a strong CYP3A4 inhibitor and has the potential to interact with other medication that the patient may be taking. Inhibition occurs rapidly after initiating ritonavir, thus even short treatment course of nirmatrelvir, ritonavir have the potential to cause clinically relevant drug-drug interaction. Ritonavir can also induce several drug metabolizing enzymes. However, since induction takes up to 2 weeks to reach maximal effect, ritonavir is unlikely to cause relevant induction interaction during the short treatment course. The patient at higher risk of progression to severe COVID-19 disease and therefore more likely to be prescribed antiviral for COVID-19 are immunocompromised patients or elderly individuals. I will now present 3 cases of patients who tested positive for SARS-CoV-2 with mild to moderate symptoms and who belongs to the risk category. I was asked to review their medication and to evaluate whether oral nirmatrelvir ritonavir treatment was possible based on the drug-drug interaction. So the first patient is a 51-year-old woman who underwent renal transplant 3 years ago. She received the immunosuppressive therapy, including mycophenolate, prednisone, and tacrolimus. Her renal function is normal. So the question is whether nirmatrelvir ritonavir interact with the immunosuppressive treatment, and if yes, is the drug-drug interaction manageable? So you can find information on drug-drug interaction with COVID-19 therapies in the specialized website of the University of Liverpool. The drug-drug interaction risk is presented with a color coding: red for drugs that should not be co-administered, amber for potentially clinically relevant interaction, which are manageable by dose adjustment or close monitoring, yellow for drugs interaction of weak clinical relevance for which no action is needed, and green when no interaction are anticipated. So let's check the interaction. Mycophenolate is metabolized by glucuronidation. Ritonavir induces glucuronidation. However, as mentioned before, it is not expected to significantly lower mycophenolate concentration since induction takes several days to reach maximal effect. So there is no need to adjust mycophenolate dosage. Prednisone is converted to prednisolone, which is metabolized by CYP3A4. The literature reports a drug interaction study with the HIV drug lopinavir boosted with ritonavir, and which showed a 30% increase in prednisolone exposure. A similar effect is expected with nirmatrelvir ritonavir. So this is a modest increase in prednisolone exposure, which is unlikely to be problematic in terms of adverse drug reaction, like the development of Cushing syndrome. However, a major interaction is expected with the narrow therapeutic index drug tacrolimus. And actually, a drug interaction study evaluating the co-administration of tacrolimus with ritonavir show a substantial increase in tacrolimus exposure, an increase by 57-fold in the AUC, as well as a substantial increase in its elimination half-life. Using modeling, this same study showed that the management of the interaction with ritonavir would require, if, for instance, tacrolimus is given at 2 mg twice daily, to reduce the dose of tacrolimus to 0.5 mg once a week in presence of ritonavir. Thus, given the profound increase in tacrolimus exposure and the related risk of toxicity, the co-administration of nirmatrelvir ritonavir is not recommended with tacrolimus unless close therapeutic drug monitoring of tacrolimus is feasible. If this is the case, then it has been suggested to halt tacrolimus during nirmatrelvir ritonavir treatment and to perform therapeutic drug monitoring to guide the reintroduction of tacrolimus treatment. And actually, the literature report real-life cases for the management of this interaction. Tacrolimus was held during nirmatrelvir ritonavir treatment, and you can see in red the first measured tacrolimus level while the treatment was held. There was no supratherapeutic concentration of tacrolimus. However, one patient had undetectable tacrolimus concentration. In black, you can see the level after reinitiating tacrolimus. It is generally advised to wait 3 days after the last dose of nirmatrelvir ritonavir before resuming co-medication due to the fact that ritonavir caused irreversible inhibition of CYP3A4, so it takes several days for this interaction to resolve. But despite waiting 3 days, 4 patients experienced a supratherapeutic tacrolimus level. One patient even experienced an acute injury, kidney injury as a result of elevated tacrolimus level. So it is important to highlight that even though most CYP3A4 inhibition disappears 3 days after stopping ritonavir, there is a large inter-individual variability in the disappearance of CYP3A4 inhibition as indicated by this figure, with some individuals still having significant CYP3A4 inhibition 3 days after the last dose of ritonavir. And this variability explains why some patients had supratherapeutic tacrolimus level. So this real-life data confirm that this drug-drug interaction is challenging to manage. So the risk-benefit of prescribing nirmatrelvir ritonavir should be carefully evaluated. In our particular case, the close monitoring of tacrolimus level was not possible to implement, so it was decided to use an alternative COVID-19 treatment. Let's move now to the second case. This is a 70-year-old man known for atrial fibrillation, hypertension, and depression. The current treatment of the patient is metoprolol, edoxaban, and escitalopram. As before, the question is to know whether a treatment with nirmatrelvir ritonavir would be possible from a drug-drug interaction standpoint. So when considering the metabolic pathway of this agent, there is no significant interaction between ritonavir and metoprolol, as ritonavir is a weak inhibitor of CYP2D6, the main enzyme metabolizing metoprolol. Edoxaban is minimally metabolized by CYP3A4, but it's a substrate of the transporter P-glycoprotein, which is inhibited by ritonavir, so there is a risk of increased edoxaban exposure. But the interaction is manageable by reducing edoxaban dose to 30 mg once daily in presence of nirmatrelvir ritonavir, as indicated by the European label. What about the other DOACs? Is the interaction with nirmatrelvir ritonavir manageable? So there is actually a drug interaction study between nirmatrelvir ritonavir and dabigatran, which showed a twofold increase in dabigatran exposure. Dabigatran is eliminated renally, so the question is how to adjust dabigatran dosage in presence of nirmatrelvir ritonavir and in patients who would have on top of that a moderate renal impairment. The label is quite vague and mentioned to reduce dabigatran dose or to avoid the use depending on the renal function. Actually, the magnitude of the interaction between nirmatrelvir, ritonavir, and dabigatran is quite similar to the interaction between dabigatran and darunavir boosted with cobicistan. And a population pharmacokinetic and pharmacodynamic analysis showed that dabigatran dose should be reduced to 110 milligram twice daily, with darunavir boosted with cobicistan in patients with a normal renal function, and to 75 milligram twice daily in individual with a moderate renal impairment. So this same dosage recommendation can be applied to nirmatrelvir, ritonavir. Apixaban is a substrate of PGP and CYP3A4, so a significant interaction is expected with nirmatrelvir, ritonavir. And the co-administration of strong CYP3A4 or PGP inhibitors is not recommended in the label, although the US label gives the possibility to administer apixaban at a reduced dose. And this dosing recommendation is actually supported by data in the literature showing that no adverse effects were observed in individuals on ritonavir and receiving a reduced dose of apixaban of 2.5 milligram twice daily, suggesting that nirmatrelvir, ritonavir could be used with a reduced dose of apixaban. Finally, a significant interaction is expected with rivaroxaban, and the label does not recommend the co-administration with strong CYP3A4 or PGP inhibitor. So for a patient on rivaroxaban, the recommendation would be to pause rivaroxaban and to use an alternative option for the anticoagulation based on the indication. So for atrial fibrillation, edoxaban 30 milligram once daily could be used instead of rivaroxaban. And we have developed with colleagues in Canada detailed recommendation on how to manage drug-drug interaction with DOACs depending on the risk, indication, or the current dose of the DOAC, like illustrated here for edoxaban. So for instance, if our patient was receiving edoxaban for the prevention of thromboembolism and the patient was at high risk of clot, it would be recommended to switch edoxaban to a low molecular weight heparin in presence of nirmatrelvir, ritonavir. Of course, the decision to use a DOAC with nirmatrelvir, ritonavir versus using an alternative COVID-19 therapy would be done on a case-by-case basis. Finally, the patient takes the antidepressant escitalopram, which is metabolized by multiple cytochromes. So it is important to know that the magnitude of DDI tend to be mitigated for drugs that are metabolized by multiple cytochrome, as metabolism can still occur through the cytochrome that are less impacted. The drug interaction between ritonavir and escitalopram was actually studied and showed only a 10% increase in escitalopram exposure. Most antidepressants are metabolized by multiple cytochrome and therefore can mostly be used with nirmatrelvir, ritonavir, with the exception of St. John wort, an herbal that has inducing properties and therefore is contraindicated with nirmatrelvir, ritonavir, as it can reduce its exposure and thereby its efficacy. So be aware that significant interaction can also occur with non-prescription drugs. Therefore, it is important to have a full medication reconciliation, including herbals or illicit drug. To conclude, with this patient, treatment with nirmatrelvir, ritonavir was possible by reducing edoxaban dose to 30 milligram once daily. And finally, the last short case is an HIV-infected patient on treatment with darunavir boosted with ritonavir. Is there a need to modify the dosage if treating with nirmatrelvir, ritonavir? So Paxlovid prescribing information mentions that patients on ritonavir or cobicistan containing HIV or HCV regimen should continue their treatment, as the additional ritonavir in Paxlovid given for 5 days is unlikely to be problematic in terms of adverse reaction. So it is easier to continue the current patient treatment. So in summary, the risk of drug-drug interaction should not necessarily preclude nirmatrelvir/ritonavir use, since many interactions are manageable. The risk-benefit of prescribing nirmatrelvir/ritonavir should be evaluated, taking into account the potential severity of the interaction, strategies for the management of the interaction, and their applicability outside a clinical setting. Full medication reconciliation and screening of interaction using specialized resources or expert consultation is advised to ensure safe prescribing. And with that, I would like to thank you for your attention, and I'd like to thank my colleague from the COVID-19 drug interaction website, as well as international colleague. Thank you.